Just a little bit about ourselves. I'm Dr. Hussein. This is Dr. Siddiqui. And we are the HerWill Reproductive Health Program leads. And we're starting a series called Her OBGYN, where we'll be featuring a series of health topics related to women's health, women's reproductive health, with the hopes that you're informed with the most up-to-date knowledge that we've gathered from our years of training. So by popular demand, we hosted a poll a month and a half ago. Abnormal uterine bleeding was one of the top two, I believe. So we've decided to present a presentation on that this time, with the plan for our future topics to reflect the other popular choices. I think PCOS and fertility, all of that will be covered. Yeah, anything else to add to that, Dr. Siddiqui?
No, just like you talked about fertility, mental health changes in gynecology, which is extremely important and often ignored, and many others. And we know that the requests for topics will be coming on in, and we are open to it. And also, this allows us to relearn the material too and refamiliarize. There's never an end to learning for anyone. So.
Yeah. And it really helps us with guiding patient counseling and figuring out what questions, your questions reflect to us what are important questions for our patients. It helps us be better doctors. So it's a mutually beneficial activity. So the format of our talk today is going to be very conversational. Dr. Siddiqui and I are very, very close friends. And so we'll be talking to each other and intermittently putting in slides that we think are important for understanding the topics that we're talking about. So why don't we just go ahead and get started? I'm going to share our first slide, which is, really just talking about ourselves and who we are. Dr. Siddiqui, why don't you tell us about your training and your background?
Yeah, no problem. So I have trained as a general OBGYN. I'm originally from New York City, and my family is still there. I did undergrad in New York City, and then I went to med school in New Hampshire up at Dartmouth. I did my OBGYN residency at Georgetown University in Washington, D.C. So it's a pretty urban city, very similar to D.C. So I was able to relate to the patients very well. I loved my time there. And the last 1 year, and I've got 2 more years to go, I'm doing fellowship in female pelvic medicine and reconstructive surgery. I can talk a little bit more about what that is, but in a nutshell, I mainly exclusively focus on surgery just of the pelvis now, and I no longer do labor and delivery, although I honestly really miss it. I miss doing C-sections. It's still one of my favorite surgeries ever. And maybe I'll go back to it one day, just not right now.
Nothing like a good primary C-section, right?
Good primary C-section is...
For breech.
Yes. Yeah,
that's what I was a breech baby. What were you?
I was a forceps assisted 4th degree. I'm telling you right now.
It makes sense that you're going into Uterine.
Yeah, away from my brother and sister. So
similar in training, we both train in the United States. So the training sort of requirements are very similar. So I'm Dr. Hussein. I grew up in Washington State, so on the West Coast, and then moved to the East Coast for medical school at Tufts University School of Medicine in Boston. And then I went to University of Massachusetts in Worcester for my OBGYN training, which is an additional 4 years. So I spent a total of 8 years training in OBGYN, and then moved back just recently to start working at a practice in Washington State. So I'm really happy to be back here to be serving my community. Unlike Dr. Siddiqui, when you complete OBGYN residency, you have the opportunity to subspecialize or just start working. So at that junction, I decided to start working. So I'm working as a generalist. So I'll be taking care of pregnant patients, delivering their babies, and also taking care of women during their routine gynecologic care. So during puberty, during menopause, and then everything in between. Any benign indications for GYN issues, I'll be there. And I'm kind of the typical OBGYN that most people see before they see a specialist. So that's kind of where we're at. As we move forward, it's important, we really want to highlight to you that OBGYN is our passion. And this is a picture of us both in the operating room. Dr. Siddiqui, what are you doing here?
Well, first of all, I'm defying one of the principles of surgery, which is never to bend. And you're always have strayed, but this was a 10-pound baby, and you do what you have to do to get the baby out. That's all that matters. So that's what I'm doing in that photo there. I don't even know who caught this action shot, but I think it's pretty good. But they clearly didn't capture the beads of sweat that I was that was staining my gowns because it was taking a while. But
I don't have great posture either. I mean, you have a total sideways, sagittal view of my back, and I've got like clearly a hunch right there. But didn't our moms tell us to soja kore bosho?
Ekdom soja kore bosho, yeah, not happening. But that's what happens when clearly in these two photos we were doing some difficult surgeries, and like you remember principles, you remember not to stay anxious, but when things happen, when things are surprising, it's survival, and you do what you can for the patient. So if my poor posture helped get that baby out, if you like kuja hoye dari thaka helped you perform that hysterectomy, that's what's important.
That's what you gotta do. I know. At the end of the day, though, our moms are always right. They're just right.
They're right.
They're always right. Always listen to your moms, especially if they're Bangladeshi.
Yeah.
So that kind of brings us to the next part of our talk, which is our partnership with HerWill. So HerWill, as we know, is a wonderful organization that's been started by many talented women with the intention of supporting women who are inspired in life and leadership, with the tremendous astronomical efforts from Farhana Hassan and her amazing HerWill team. We've been able to partner with them and use our expertise to kind of talk about these issues on a validated platform. It's amazing. This collection of women is amazing. I've never seen a group that's so diverse, from architecture, engineering, business, whatever field that you mentioned. Bangladeshi women have made it everywhere, and this group is very unique. I don't know if you feel the same way, Dr. Siddiqui.
No, I mean, I couldn't even believe that there were. Sometimes when I talk to just you, Dr. Hussain, I feel like it's so nice to have just one person who can relate to me, and then I see that there's a community of possibly 20,000 of us. It's almost like, where have you all been our lives? It's so nice to finally meet you.
Exactly. It's amazing. And at the same time, while we're surprised, I'm also not surprised. Bangladeshi women are incredible. Like some of them, resilient, smart, kind,
hospitable.
So hospitable, such good cooks. I think really pretty too, right?
Bangladeshi women, they're the prettiest women in. I'd like to look like one day, but
we're a little biased. I'm going to say we definitely have some biases here, but in actuality, really, Bangladeshi women are amazing, and so I'm not surprised. I think the big take home for us is, this is a platform of so many qualified women. We want to be there to help you and donate our time to answer your questions regarding your health, and with the hope that you pursue the care that you need with your OBGYN. But also on the side note, we hope that this conversation ignites that passion to be a mentor and to be mentee. We are in our subspecialties in healthcare, but there are so many communities in our group. Architecture, business, and there's so many qualified women who have reached a certain point in their life where they can pass the baton down to a different generation, right?
Yeah, no, completely. And I just feel like so many times, younger Bangladeshi women probably, I don't want to use the word go astray, but just don't get the mentorship that they need to be able to fulfill their goals. And then eventually they just do something that they think will just fit in their lives rather than pursue their passion. So I think it's really important, especially those of us who are comfortable where they are. I know I certainly have a way to go, and I still have mentors. If I can serve in the capacity of a mentor to someone else, that's it. That's just perpetuating all the goodness that we bring.
Exactly. I think we've all benefited from amazing mentors, and we're continuing to be, and it doesn't have to be someone in your field. We've got members in HerWill who are acting as great support members for us. And so we even help each other out when we're on call or text each other about certain patients. So, finding your tribe, finding your people, a group of women who cheer you on and make you a more a happy, successful person is what we want. So go seek that. Dr. Siddiqui, do you want to talk a little bit about the goals of the Her OBGYN series?
Yeah, absolutely. So everything that Dr. Hussein had said, obviously I want to echo and don't want to take up too much of your time. I believe everything that in her commitment very well. The main things that we also do want to highlight is that throughout this whole talk, our goal is to educate you and empower you so that when you do see your physicians, you know the right things to ask, the right words to use, the right language, because that's so important for you, because it allows you to take an ownership of your health. And trust me, I think this is unique and universal to women everywhere. But I know, especially Bangladeshi women, they will care about the thousands of other people before themselves. So our talk is to equip you with the educational resources that you need to be able to speak freely and candidly with your doctors. Unfortunately, today, even though Dr. Hussein and I are both physicians, what we're telling you today, we don't want you to confuse for treatment necessarily. We would love to, but we unfortunately can't serve in the capacity of your physician today. So I don't want the take-home message to be that this doctor said this, so I must do that. Everything we say, please talk to your own doctors about, so that you can come to so that you can always make an informed decision. It's all about you.
Exactly. Information is power. And to further add on to that, we want to insert the caveat that both Dr. Siddiqui and I are US trained OBGYNs. So a lot of our recommendations of treatment prevention data comes from as a reflection of our training in the United States. So it might not necessarily reflect the standard of care in the rest of the world. But this is our personal experience. It's our story. And we hope that it gives you more information and context when you have your conversations with your OBGYN. Anything else?
No.
So let's move on to our first topic, which is abnormal uterine bleeding. This was chosen by popular demand, and we're really happy to talk about this. This is a very, very broad topic. So we're going to be very broad in our descriptions and try to keep things very simple for all of you. So before we talk about abnormal uterine bleeding, I think it's really important to talk about what's normal uterine bleeding and what's normally to be expected, because when we deviate from that, then we know it's abnormal. And so before talking about that, just kind of knowing the basics of pelvic organ anatomy, we have the uterus, which is a muscle inside the pelvis that we all know about that houses a pregnancy. On each side of the uterus, we have two small fallopian tubes that are lying close to the two white structures, which are the ovaries. The ovaries house our eggs, and the ovaries are also a source of hormones for us, which help regulate our menstrual cycle. When you look at the inner lining of the uterus, that lining is called the endometrium, and that lining sheds every month to cause which we perceive as our menstrual cycle. And at the base of the uterus, or the opening of the cervix, opening of the uterus is the cervix, and the vagina is more distal to that.
So when we talk about our uterus is bleeding, it's not literally the whole uterus. The uterus in a normal woman is actually a fist size. A woman who's not pregnant, it's really this big. It's kind of small. It's not that the whole thing bleeds. It's the inside that bleeds, and that's what your period actually is.
Exactly. And so when we think about the menstrual cycle, there are hormones that are key in creating that cycle. So the two big, I like to think of the menstrual cycle as two phases. There's the follicular phase and the luteal phase. Long story short, the most important take home from this is that the luteal phase is the constant phase. That's the phase that's always going to be 14 days. And the follicular phase is the phase that ranges from 14 days to 21 days. And so cumulatively, that's where the variation in the menstrual cycle happens. So person A might have a 28-day cycle and person B might have a 32-day cycle. And the difference is because there are differences in the follicular phase. There are two important hormones that are also part of the cycle, estrogen and progesterone, which I'm sure you've heard about. The difference is estrogen is the hormone that's kind of the female hormone. It's what's responsible for our secondary female characteristics. But in the context of the menstrual cycle, it's responsible for thickening the endometrium and increasing the stringiness of the cervical mucus. This allows for fertilization if it were to occur. Progesterone is the other hormone, which is secreted from the corpus luteum after ovulation of the egg. So when the egg ovulates, it travels through the fallopian tube. If it does fertilize with a sperm, then it can result in a pregnancy. And so when the egg ovulates, there's a corpus luteum in the ovary that's secreting progesterone, and it's secreted to help support the pregnancy if a pregnancy or fertilization were to occur. From an endometrium standpoint, progesterone actually stabilizes the endometrium. So instead of causing that growth pattern that estrogen does. I wanted to use this time as an opportunity to talk a little bit about combined birth control pills. So birth control pills, while they're used for birth control, actually, at least in the US, more commonly is used to actually regulate and help with bleeding, right, Dr. Siddiqui?
That's exactly what I tell my patients. I mean, birth control can have that stigma in that it can make people think that they will be like irresponsible with their behavior, but that's not necessarily it. I honestly don't even remember how many times I've prescribed birth control just for the virtue of it controlling birth. The majority of the times I've prescribed birth control is purely for the regulation in the bleeding. So when we think about that slide that Dr. Hussein showed us with the different phases, initially, the first part, which is the follicular phase, that's the phase where the ovary develops the egg that's supposed to release, and there's this whole estrogen surge that happens. And then the second part of the menstrual phase really focuses on the uterine bleeding side. What birth control pills do is help with that estrogen and progesterone regulation better so that you can have a period that is more timely. And we'll talk a little bit. We have a couple of frequently asked questions that doctors ask their patients in order to better gauge what is a normal cycle for you. So all of this will make more sense.
Yeah, and then so when you have birth control pills, there are two kinds. There's the combined that has both estrogen and progesterone. And when there's estrogen and progesterone, you have to remember that there are certain people that can't take that. So if you've ever had a blood clot, so not bleeding clots, but blood clots in your vessels, you should not be taking any estrogen-containing products because birth control pills, because estrogen can increase your risk of having a clot, which can be fatal. If you also have a history of migraines with aura, which would mean visual changes or some of the neurologic side effects that come with a migraine, you should not be taking any estrogen-containing birth control pills. But those are just kind of little tidbits and facts that you should know.
Yeah. I've done in practice a lot. It was if a patient has uncontrolled high blood pressure, then I don't give them anything that contains estrogen because that can increase and make it worse too.
Exactly. Smoking as well. If you're smoking and you're older than 35. Yeah.
When you're smoking, your risk of getting a blood clot in your legs that can travel to your heart and your lungs is way higher. So we have other options for you are in that group.
Yeah, but that given, it's very safe. It's very common. Lots of women take it. Don't be scared of the medication. But that's just helping understand that a lot of our treatment for abnormal uterine bleeding comes with targeting various aspects of this cycle. So Dr. Siddiqui, what's a normal menstrual period?
So I get this question almost all the time. And even though my patients now are more in the postmenopausal, so after age 52 category, I still get these questions because a lot of them come to me about questions about their daughters and their granddaughters. So what is it? Is it a period that happens every month, every 3 weeks? What is the actual definition? So a normal cycle can last anywhere from 21 to 42 days. That does not mean that you bleed anywhere from 21 to 42 days. That is not normal. What is normal is getting a period, which lasts anywhere from 5 to 7 days, every 21 to 42 days. That is still normal. So if you are on the 21 day end of the spectrum, you might be somebody who gets her period the first week of the month as well as the last week of the month. And if you're somebody who's on the other spectrum or other end of the spectrum, you might be somebody who gets a period every 6 weeks. That is still normal. Other questions that we try to ask when it comes to what is normal or not normal about your cycle has to do with flow. I'm sure you've watched commercials about having about like sanitary pads and napkins, and they talk about having a heavy flow. But this definition varies very, like, extremely significantly. So questions that we like to, and jump on in, Dr. Hussein, but like questions I like to ask my patients are, okay, so you tell me that you think you have heavy bleeding, but tell me this. When during an average day on your period, how many pads are you going through in an hour? And I'm not saying that how many pads are you just briefly staining and then changing. I mean, talking like bleeding through, ekdom like bichana bhashiye dawar moto obostha, like it happens. It's something like that. How often does that happen to you? That is a really key way I can figure out if it's heavy or not. Do you end up seeing large blood clots? Sometimes some of the clots can be like small. One way I like to ask my patients is like doing fruit analogy. So is it like a grape-sized clot, golf ball sized, an orange?
Bangladeshi fruits.
I've had patients say that like they at times have passed like cantaloupe or gatal-sized clots. That is not normal. That should not happen. And the other thing that, I feel like, Dr. Hussein, this is normalized in other countries, and it really shouldn't be, and we're finally not normalizing it here, but missing school and missing days of work for your period, that should not happen. And if that is happening, then we are worried about your health. In Bangladesh, like how many times, Dr. Hussein, have you heard that, school jete parche na because of ei karone, prottek mashe koyekta din school bad jay? That's not, that's not good, because it interrupts a young girl's life, her productivity, her like independence. So that's why we like to ask these questions, because it helps us understand, are we really having an issue, or is it just a heavier period, but she's managing well?
Right. And this is really important, because when you're talking to your physician, it's really important that we get the data that we need to help assess what's going on. And knowing the answers to these questions are really helpful. So giving us vague answers like, I'm bleeding more, I'm changing my pad all the time, it doesn't give us valid information. Telling us how often you are. Sometimes I even tell my patients, I don't know if you do the same, Dr. Siddiqui, to take a picture of the pad or the blood. It gives us so much information into what's going on, what's happening to you.
Yep, definitely.
So abnormal menstrual bleeding is if your answers to any of this question is no. If you're at all unsure, or if your answers to any of those questions are yes, then you should be worked up for abnormal uterine bleeding. So here's a quick table to kind of summarize the parameters to give you more concrete definitions for what's normal. So looking at the frequency of menses, normal, as we defined, is 24 to 38 days. So anything less than 24 days is too frequent, and anything more than 38 days is considered infrequent.
21 to 42 is what a lot of other sources say. Bottom line, like the range is large, but you shouldn't be having a period like 3 times a month. That's not normal.
Exactly. The regularity of menses, the variation should be less than 7 to 9 days. So, it shouldn't be longer than that. In terms of duration, a normal flow is less than or equal to 8 days. So if you're bleeding more than 8 days, that's, should be a little red flag for you. And in terms of blood loss, I like to quantify things for patients. I personally just learned this a month ago as I was studying for my boards, but a super tampon saturates 30 milliliters of blood. So it just gives you context. So normal blood bleeding is 5 to 80 milliliters for a cycle. So if you are soaking through multiple of those super tampons, that's already getting you to 90 milliliters. Like, that's not okay. So just getting a sense of what your blood loss is. All right. So there are many causes of abnormal uterine bleeding. How do you like to categorize it, Dr. Siddiqui?
Yeah, I think one of the best ways to talk about it is by age group, because whenever I have a patient come to my office, the first thing I look at is age, to see like how I would or what kinds of questions I would ask, and that can like gear me towards like my workup and then eventually the management and treatment part. And feel free to jump on in, Dr. Hussein, but the main three categories that we like to look at are the preteen and teen years, so like childhood to early adolescence, the adult reproductive age, which ranges usually from 18 to 52, and the postmenopausal time period. We can first start with the preteen and like teen era, so to speak. But before we go on, do you have anything to add, Dr. Hussein? Is there any other age code? Okay. Yeah. So basically, in the preteen and teen age cohort, first of all, just to let you know, in the United States at least, the average age for menses is around 11 to 12. It is actually like decreasing every year, and I think a lot of it has to do with all of the hormone and genetically modified food we have here. But for the most part, that's like the average. Internationally, I believe it's probably around 12 to 13. Anyways, like just at hitting the adolescence time period. So the main reasons why an adolescent would have irregularity in bleeding, and the main irregularity usually is something like, I got my first period and then didn't feel anything at all, and then 6 months later I got my second one. That completely happens, and that's normal. What happens is that earlier we showed you a diagram of the menstrual cycle, so we really focused on the ovary and the uterus. When your period starts, like in a young woman and a young like girl who's just transitioned to teenhood, basically your brain, ovaries, and uterus need to work together, okay? Because there are hormone releasing hormones. It's like there's a hormone for a hormone for a hormone.
Yeah, exactly. Yeah.
So the brain actually sends out hormone releasing hormones to the ovaries, and then the ovaries act on the uterus. So what's happening in these young kids whose brains are still underdeveloped or developing is that brain, ovary, uterus linkage has still not solidified. And so when that happens, bleeding irregularity is totally normal, because bleeding is at the whims of what's going on with your hormones. And if your hormone status is fluctuating because the connection has not truly optimized, then that's when irregularities happen. And that's completely normal. Your brain doesn't even fully develop until you're 25. So this is okay. But that's usually what happens. And unfortunately, a lot of these younger girls, one of the things that could end up happening with their irregularity is that some of their periods can become extremely heavy. And these are the girls that miss school. They miss their like sports club. They miss their nacha classes. Like I have some of my friends who couldn't go to their kuchiburi classes because of these things. So that's why like it's super important for us to be able to handle it, because even though we know that once their brain, ovary, and uterus start to communicate more, the periods will become more regular. That much blood loss in a young girl is not good. It can really hurt her. Like maybe somebody of my adult age can withstand losing a little more blood, but these young girls can't. They're still pediatric. Even though in our culture, everybody says, like, after you get your period, you've become a woman. This is still a pediatric age patient. So blood loss for her is a big deal. Mm-hmm. What are some ways that we can handle this? So Dr. Hussein talked about birth control pills. And I think this ends up being really sensitive for a lot of our moms of these young girls, because they think that it will forget about the not regulating their periods. It just might like get them to behave in ways that they're not supposed to. Or maybe some parents just don't want the idea of their children being on any kind of outside hormones. We understand, but when it comes to bleeding control and your daughter's like health and life, that's usually what ends up being most important for parents anyways, especially our Bangladeshi moms who will we are their John Pran, right? So they'll do anything for us. Once we really communicate to them that the birth control pills are designed to help with hormone imbalance and hormone structure and hormone regulation. And that is what then eventually helps with the heavy bleeding. So in this photo here on the left-hand side this is like when you get prescribed birth control pill, this is what the pharmacist hands you. So the first 3 weeks are these like white pills. These are the pills that contain hormone. The fourth week, these are what we call the sugar pill week or the placebo pill week. And what happens is that you still take those every day, but there's no hormone in it. It's just either a sugar pill or a nothing pill. During that week is when you have your period. So as Dr. Hussein said earlier, it's the estrogen that builds up the blood in the uterus, and it's the progesterone that finally allows you to release all of that. Basically, when the hormone in your body, the levels go down, that's when you actually have your period. So that fourth week with the placebo week, if you are not taking any hormones, that's your body's allowance to have your period that week. And I think like when
fourth week, kind of like the sugar pill week, they're literally sugar pills.
They are sugar pills.
They're not doing anything hormonal for you.
Exactly.
The hormone. Yeah.
Right. Like, I mean, a lot of patients also ask me like, hey, should I even take it? Theoretically, you don't have to because you're not taking any hormone pills. However, it's good to stay in the habit of taking the pill every day, because if you don't, then like, unfortunately, in those settings, your ovary and your uterus is not very forgiving. If you miss a pill, you'll feel it in some way.
Especially for teenager patients who are going to be so busy, having that regularity and habit is super important. And just to add on to this preteen population, something for mothers to recognize, I don't anticipate we have too many teenagers in the audience, but we might, is that this is a scary time for them. They don't really know what's going on. I mean, we in the US had a health class where we learned a little bit about it, and I don't know what it's like in other parts of the world, but it's really scary. So, communicating with your daughters and letting them know it's okay and validating their symptoms and feelings are really important. And also really being proactive and letting this not affect their schooling, because girls missing school for something that we can help treat should be prevented. You don't want to put our daughters behind their male colleagues. If they are not having if their symptoms are not being resolved, we should be proactive about that, because it's only going to help them do better in school.
Yep. That's the biggest takeaway. And I feel like so many girls, they end up like shying away and not wanting to talk about this because this topic is stigmatized. But that's why we're here. That's why we have this like lovely viewership, because we all agree that this shouldn't. We should know more and educate more. So just going back to this slide, there's also this like little box here of iron tablets. Whether you take any sort of hormonal control or hormonal pill or not to control your cycle, one thing we definitely recommend for women who even have heavy periods but not necessarily abnormal is to take iron pills, because every time you lose blood, you lose red blood cells, and red blood cells carry iron, and iron is what red blood cells need. So no matter what, take it. One of the side effects, it's annoying and unfortunate, is that it can give you some constipation. So expect that. Increase fiber in your diet, and take them there are you don't even need suppositories. I don't think it gets that bad, but usually there are many over-the-counter
or something like that.
Oh yeah.
Or also make sure to take it with a little bit of vitamin C or orange juice to increase the absorption of the iron.
For sure. Don't like kalipite keona, kind of thing. And in that same photo, if you can show that to us, Dr. Hussein, again. Okay. So one of the things that the photo on the right, it's called an intrauterine device, or an IUD, and that's what we're going to be calling this throughout the rest of our presentation. This is not found, and it's so sad for me to hear this, but this is not found in like other areas of the world as commonly as this is found here. So this is an ideal way for us to control for heavy bleeding, because what this device is that we insert it inside of the uterus, and we'll talk about that process too. It contains very small amounts of progesterone hormone that is released every day. And remember, the progesterone hormone is the one that stabilizes the inside of the uterus lining. So that's the hormone that doesn't make the uterus build up with blood, okay? So this is ideal for patients who have like very heavy bleeding, for whom maybe the pills didn't even work. And just inserting it inside of the uterus helps it have a local effect just on the uterus. And it doesn't give you that hormone effect in the rest of your body. It just kind of stays in the uterus, which is nice, because so many people, so many patients are just worried about taking extra hormones because it'll affect their mood and all of these things, which is totally valid concerns, but this stays in the uterus.
It's amazing. I think in the United States, the most common form of contraception used amongst physicians is the Mirena low-dose progesterone IUD. So
this stays in. Right. This stays in for anywhere from 5 to 10 years, depending on what you get. So this is not like you insert it every day, remove it, insert it. It's not like that. It's not like taking a pill that you have to do every day. This stays in for 5 to 10 years. And sometimes, you forget about it. I know so many people who literally have completely forgotten that they have this.
It's great for patients, for people who have a hard time remembering or don't want to take a pill every day. This is something to keep in mind.
Yeah. This doesn't get rid of your periods, but for the most part, for women who've had it for a long time, your period ends up getting thinner and thinner and thinner in terms of flow, and then it goes away. So, yeah.
It's great. So next category, we're running like 35 minutes in, so we have 10 more minutes. I want to leave some time for questions. We're going to move on to the next category, which is reproductive age women. So women from the ages of 18 to 51. At this point, our menstrual cycles have matured a little bit. Now we're more regular, or we should be anticipating more regular cycles. So there's a variety of causes of abnormal uterine bleeding at this age. And so as OBGYNs in our teaching, we've categorized the causes in 2 different large subgroups. And it's actually summarized in a funny acronym. It's called PALM-COIN. So PALM being PALM, and COIN is COEIN or COIEN. So PALM summarizes the structural causes of abnormal uterine bleeding. So I'm going to just quickly share a slide regarding that. So P standing for polyps, A standing for adenomyosis, L standing for leiomyomata, which is another fancy word for fibroids. I'm sure you've heard of that. And then M standing for malignancy. So these are all benign causes of abnormal uterine bleeding, with exception to the M, which is malignancy. So polyps, in a nutshell, are, when we talked about the endometrial lining, having little outpouches of that, or growth of that endometrium can cause abnormal bleeding in the setting, can cause heavier periods. It can also commonly cause spotting in between periods. So that's something to think about. They're typically benign growths. They just need to be resected if they're becoming bothersome. The second category is A, adenomyosis. Adenomyosis is when the endometrial lining inside the uterus starts to grow inside the muscle. So the uterus, when we see these in laparoscopy and surgery, patients with adenomyosis have a very globular, like round at the uterus, and their periods are very painful because that muscle is contracting with endometrial cells inside of it, so it can be very painful. And actually, the only way to diagnose adenomyosis is by pathology. So actually, we have to surgically remove the uterus, slice the tissue up into thin slices, and look at it underneath the microscope to see evidence of endometrial cells inside the muscle to be able to diagnose adenomyosis. Obviously, it's not feasible. So it's sort of a diagnosis of, we kind of clinically diagnose patients if we've ruled out other causes. Fibroids, which is the L, is the most common broad category. I think I read a statistic that by the age of 40, 70% of women at least have fibroids. I have a fibroid. I have a 2-centimeter little baby fibroid at the lower part of my uterus. It's extremely normal. In fact, it's probably abnormal to not have a fibroid by the time you're in your 40s. So fibroids can happen anywhere. So if you think of your uterus as a muscle, if you have fibroids on the surface of the outer surface of the uterus, apart from bulk symptoms or maybe a little bit of pain, you might not really feel anything. It's when that fibroid starts to grow inside and disrupt the inner endometrial cavity is when you start having abnormal bleeding. You don't even have to have a big fibroid. Just check out the fibroid. If it's disrupting the endometrial cavity, you are likely to have abnormal bleeding. It's benign. It's almost always benign. And The only time we take fibroids out is when you're having symptoms from it. So either bulk symptoms or significant bleeding and anemia that's disruptive. Thankfully, fibroids go away fibroids thrive in the presence of regular hormonal stimulation. So in the postmenopausal women, fibroids should shrink up and resolve because you're not getting that endogenous hormone stimulation. Last but not least, yeah, go ahead, Dr. Siddiqui.
Say that you mentioned bulk symptoms a couple of times, and just to clarify what that means, other than bleeding, as Dr. Hussein said, the fibroids can cause bulk symptoms, usually the fibroids that are on the outside. What bulk symptoms means is something like a fibroid that's so big that's it's sitting on your bladder, kind of. So if you can imagine, here is the uterus. In front of it is the bladder, and behind it is the rectum. So if there's a big fibroid sitting here, it can sit on top of your bladder. And a lot of my patients mainly come for uterine and bladder issues. So many times my patients tell me something like, doctor, I feel like when I sit down to pee, I can't empty completely. And then you do an ultrasound and see, oh, well, there's a big fibroid that's not supposed to be in your uterus that's sort of disrupting your bladder. So that's what bulk symptoms means, literally feeling like you have something. Some of my patients have told me, I feel like I'm pregnant all the time. And that's what that means.
Yeah, exactly. They're huge. And depending on their location and size, there are different surgical or non-surgical treatments for them. Last but not least, but very important, is malignancy. Malignancy, money, cancer. Is it common? No. Most young, healthy women should not have cancer. But can it happen? Yes. So we always, always, always have to think about it and keep it in the back of our mind and rule it out. The most common way to diagnose it is doing an endometrial biopsy, is where we put a little straw through the cervix and sample some of the endometrial tissue, send it to pathology. The pathologists look at it under the microscope and tell us if it looks like cancer or not. The most common type of cancer we're talking about is endometrial cancer. Endometrial cancer is actually pretty common in the US. It's I think the most common gynecologic cancer. And the cases are rising because the risk factors for endometrial cancer are rising. So and these are things that affect Bangladeshi women. So obesity is a risk factor. Diabetes is a risk factor. I know diabetes is very common. Family history of endometrial cancer, and there are various other risk factors. But if you're diabetic, if you have diabetes, if you have abnormal bleeding, does it mean you have cancer? No. It just means we need to be on high alert, and depending on your age and depending on your discussion with your OBGYN, the decision to sample will be made. So just keeping that in the back of your mind. And the main take home from this is endometrial cancer is very curative. It's actually, our treatments for that are really, really good if we catch you early. And so how do we catch you early? Is you seeing your doctor soon. Nothing makes us sadder than seeing a patient who comes in when it's too late. If they had just come a year earlier or a couple months earlier, it could have been life-saving. So it's important to keep that in mind. I know with the pandemic, it's difficult to see the doctor, but hopefully these things will help you kind of figure out when it's important to go. So the second category is COIN, which is COEIN. These are the non-structural causes. They're less common, but something to still keep in mind. C standing for coagulopathy. So any inherent bleeding disorders. If you're prone to bleeding from your gums, from your incisions, because you have an inherited bleeding disorder, obviously you're going to bleed from your uterus too. So that's something to keep in mind. So in that case, treating a structural defect isn't going to help. It's going to be treating your underlying coagulopathy that's going to help. The second one is ovulatory dysfunction. And the big one we think about is PCOS, right, Dr. Siddiqui? And that was a very popular topic. That is a whole nother presentation in itself. We'll get there, but it's polycystic ovarian syndrome. And long story short, these women have anovulatory cycles, so they're not ovulating regularly, and that results in abnormal buildup of endometrium, and that results in abnormal shedding as well. And then other things like iatrogenic, which means if you're taking medications that thin out your blood, like Coumadin or Lovenox or heparin, these medications are going to thin out your blood and increase your risk of bleeding. So that's kind of the second category. And treatment for this, we're going to talk about in a separate slide, is very similar to what Dr. Siddiqui talked about with the preteen population. I want to share a quick slide on fibroids because they're very common. And this is a slide that shows on the right a normal uterus with the normal anatomy that we talked about. And on the left, how the uterus can look when you have these fibroid growths. And depending on their location, they can cause different symptoms. And remember, even though we're calling it tumor, it's still benign. It's not, or very unlikely to be cancer.
That's a quick thing.
Yeah.
If you are somebody who has been, and this is not actually very common, but only because among Asian women, this has been on the rise a little, and that's the only reason I'm bringing it up. If you are told that you have a fibroid and then a month later it has grown a lot in size, that can be a cancer. So definitely if your fibroid has grown a little bit here and there in the last like 3 or 5 years, that happens, that's okay. We can talk about things to do next. But if it has rapidly grown, then that's a concerning thing. Not very common in general, but it actually has been on the rise in like Asian and South Asian women. So just want to, make sure we keep everybody just on alert. Like, we all need to know. That's all.
Exactly. I think that kind of leads us to the postmenopausal age group, Dr. Siddiqui. What are common causes of abnormal uterine bleeding in this population, since you see them more often than I do?
This is my patient population. I love my postmenopausal, lovely, lovely women. So everybody, the average age for menopause in the US and really actually internationally now is 52 and a half. Okay. Around the 52 to 53 time, like age cohort, and around that time, you should be experiencing perimenopausal changes. And we can have a whole discussion on just like things to expect. But that is the average age. Does that mean you're definitely going to have menopause by age 53 or not? No. But by 54, 55, if you're still having your period, that's what we would then actually call abnormal uterine bleeding. And we need to investigate as to why that's happening. In general, the most common reason that a postmenopausal patient would have bleeding is really because of vaginal dryness. And I know it sounds ridiculous, and it's probably something that a lot of us have not thought of, but the vagina is very similar to the skin, but actually even more sensitive, which I'm sure you all are like very aware of. But when your skin has less blood flow, it becomes more cracked. And then when your skin cracks, especially like think about it when you're out in the cold, it can bleed a little bit. So that's what happens in the postmenopausal vagina. It actually becomes less rich in blood supply, which then contributes to the dryness, which then kind of sort of causes like little cracks. And that's what can bleed. Any irritation of it can bleed. Patients with really severe disease, like literally if you touch it, can bleed. So that is the most common cause of postmenopausal bleeding. However, the more concerning cause is cancer, less common, but more scary. So we always want to rule that out. We always want to make sure that even though she's telling me she saw a little spot in her underwear and it's because she has vaginal dryness, I still want to make sure that it's not blood that's coming from inside of the uterus, because bleeding from a dry vagina is completely different from bleeding from a uterus. You should not be bleeding from your uterus after menopause, with no exceptions. That should not happen. Bleeding from your vagina makes sense because there's less blood supply, it's drier. In general, how can we fix vaginal dryness? There are many different things that we can use. I, in general, tend to recommend non-hormone-based therapy, and that's actually what the majority of my patients want to. So water-based lubricants to help. And this is not just for things like to help with intimacy, not just that, but really just for yourself. Some patients have such a terrible time that they really can't even wear their underwear. And that increases the risk for UTIs, infections, and any urinary tract infection increases your risk for upper urinary tract infection, So that's why we just want to make sure that this is a problem that, because there's such an easy and available solution, we educate our patients about it. Even though I like saying start with water-based lubricants and see if that helps, my favorite thing actually is to prescribe vaginal estrogen, because it is a very, very tiny amount of hormone, and we can, again, also have a whole whole talk on hormone replacement therapy after menopause because it warrants a whole topic. But the amount of hormone in a pea-sized amount of vaginal estrogen is so small. It will not travel to your whole body. It'll just stay in the vagina and do what it's supposed to do. Estrogen is a little different from just regular lubricants because estrogen is now then going to bring back that blood supply that you had lost. When you have blood supply, you have moisture, you have less bleeding. That's it. So it's super easy to like wrap your brain around, but so many times we try to figure out where could this bleeding be coming from? And a lot of times, especially like when we get older, it is hard. Where is the bleeding coming from that I noticed on my underwear? It could be from the rectum. It could be from inside of the urethra because everything is really close down there. A lot of times just having a urinary tract infection can cause you some bleeding and you don't know if that bleeding is from your urine or from your vagina. Either way, you need to tell us, and we as your doctors, it's our job to figure that out.
And the main take home is if you're postmenopausal, and menopause meaning you've not had a period for 1 year, okay? And if you're having any bleeding that is not normal, you 100% should get that evaluated within the next few weeks. Another thing, Dr. Siddiqui, do you use narcolepsy there or recommend patients to take coconut oil as moisture?
Yeah, narcolepsy works really well. If you... Yeah, well, vaginal estrogen can be a little bit expensive. It works wonders, but it can be a little bit expensive. So no, like over-the-counter, easily available things like narcolepsy actually works pretty well.
Awesome. And so Dr. Siddiqui was talking a little bit about, OBGYNs, us knowing where that bleeding is coming from. That kind of takes us segues into our next topic, which is kind of like a really important topic for us, which is what to expect at your OBGYN's office. So, Dr. Siddiqui, I'm sure, does the same thing. But when a patient comes in to see me, the first important thing, we kind of go from least invasive to more invasive in our evaluation of a patient. And the first one is to really meet the patient, greet the patient, say hi to the patient, and learn everything about their medical and surgical history. So your OBGYN should really sit down and dedicate some time learning about everything about your medical history, what surgeries you've had, what medications you're on, your family history. And then, of course, what is the nature of your abnormal uterine bleeding? Are you having clots? Are you soaking pads, 2 pads a day, 3 pads a day? When did it begin? When was it normal? Everything. Have you been worked up for it before? It's really important that you use this time to talk very openly and frankly with your OBGYN. You should talk about your sexual history, whether or not you're sexually active, and you should feel safe enough to mention anything and everything about your life without any judgment or assumptions from your OBGYN. Do you have anything to add to that, Dr. Siddiqui?
No, because the more I know, the more I can keep you safe.
Exactly. So how do you go forward with the physical exam part of the visit, Dr. Siddiqui?
Yeah, so it's extremely important, especially if the chief complaint for my patient is abnormal uterine bleeding. I know this is not I don't think I've ever met anybody who's enjoyed a pelvic exam, but we do really need to do a thorough pelvic exam to be able to appreciate what kind of, or get to the bottom of what the cause for abnormal uterine bleeding would be. So pelvic exam entails having to sit on, you all have seen like the regular office beds or hospital beds. So basically you would first lie down, and then there are these footrests that come with that bed. You would place 1 foot on each side. And again, not every woman has experienced this until she absolutely has to, which is what we're trying to prevent, because women's healthcare is part and parcel of regular routine healthcare. So we want to normalize getting pelvic exams, even though it's not fun and not great. So you would then lie back on this office or hospital bed. And what we would do is we would show you this device. I don't know if Dr. Hussein, you can show us a photo of it. Basically, this is called a speculum. And it looks scary, but we usually end up like adding lubrication to it or running it under hot water so you're not caught off guard. And I like to take I kind of gauge what my patient wants. If she is somebody who's just like, I even ask her, how do you want me to go about it? Are you somebody who wants me to just get this done? Or would you like for me to talk you through every single thing that I'm doing, which is personally what I do like to do. So it's important that your doctor meets you where you want her to, or him or her to, because this can feel traumatic if you are not ready for it. So basically, we use this device. It's called a speculum exam. We insert it through the vagina, and then it allows us to see the cervix. And remember, the cervix is the opening to your uterus. So if this is your uterus, the cervix is down here. And just as an FYI, this cervix is what thins out at the time of pregnancy, but this is not about pregnancy. So the cervix is this really thick structure. It kind of looks like a doorknob. And the speculum then allows us to see it and take a look. Like, is there something on the cervix that might be bleeding? Is that why she's having issues? So that's the first part. And then the second part is a little less invasive, and it just requires us doing an exam with our hands. Like, if I can clearly feel, like, one hand would be inside of the vagina and my other hand would be on top of the uterus or on her belly, and I can try to see, maybe there is a fibroid here. Oh, I understand why she's having a hard time peeing. There's a fibroid right here on top of her bladder. So that really helps. And do you want to talk a little bit about the probe here, Dr.
Yeah, and just to add on to that, I'm sorry if you already mentioned Dr. Siddiqui. This is a really important part of our data collections point. A lot of our South Asian patients, Muslim patients as well, tend to decline this exam and not want it. And we really want to emphasize that it's very important for us. And strategies to make it a little bit more comfortable for you is having a friend or a partner with you to hold your hand, relaxing your bottom as much as you can. So you'd be asked to put your legs up on stirrups and your bottom will be at the edge of the bed. Ideally, your OBGYN should talk you through it, or may not, depending on what you prefer. But there shouldn't be any surprises. I mean, a lot of it's mindset. If you can keep your mind calm and relax your body, it's not as terrible of an exam. And it really takes like 45 seconds. The other thing I did want to mention as well is that typically there should be a witness in the room as well. Especially if you have a male provider, there should be another person in the room as well.
Also, one thing I wanted to say that I know I forget routinely is we do this exam with your consent. We will not do it if we do not have your consent.
Correct.
So many times, I don't know if Dr. Hussain, you've experienced this, but in my training, so many times I would get calls from doctors at like an ICU who says that this patient who is intubated has no awareness of her surrounding, is very, very critical, but they really want you to do a pelvic exam on this patient. I always decline. I will not do a pelvic exam unless her life is threatening, which in the office is usually not the case. But a pelvic exam is an intimate but important exam that we can only do with your consent.
Exactly. And then kind of extending it further, in addition to the pelvic exam, your doctor might order a transvaginal ultrasound. So there are many different kinds of ultrasounds. The ultrasounds you probably know about are from pregnancy, where the probe is on your belly when you're looking at the baby. But the transvaginal ultrasound, I'm going to show a picture really quickly, is this probe that goes through the vagina and sits right next to your cervix. The reason why this ultrasound is more preferred over the transabdominal is that it's the closest to the uterus. We want to see the uterus, we want to see the ovaries, and the best way, the closest we can get, is using that probe. So giving us consent to do that is really, really important. Typically the probe is covered with it should be covered with a sterile glove, and there should also be lubrication and gel on it, so it shouldn't be as uncomfortable. If you've had an early pregnancy dating ultrasound, you probably experienced this. It's an incredibly informative imaging modality for us. A lot of patients at this point are like, can I have a CT? Can I get an MRI or X-ray? No, those imaging modalities do not give us the information we need, are expensive and time consuming. So for many reasons, we do not recommend alternative imaging modalities. So briefly, treatments that we have, we've talked a lot about them. First and foremost, expectant, which is doing nothing. If you're not bothered, if your blood counts aren't abnormal, if it isn't life-threatening, women can choose to do nothing. Another category is medications. We talked about progesterone-only pills or birth control pills to help regulate cycles. We also talked about the intrauterine device, and I think we have a couple of questions about them, so we'll address it then. A couple of more atypical treatment, not atypical, but treatments that might not be universal, is something called a uterine artery embolization. This, I don't know how common this is in Dhaka, but in the United States, it's performed by an interventional radiologist. So an OBGYN does not do this. It's a radiologist who has trained in interventional radiology. And long story short, it basically tries to decrease the blood flow to the uterus. Because if you think about it, if you're bleeding from your uterus, one way to help decrease the bleeding is decreasing the blood flow to the uterus. So they can put little agents, hemostatic agents, or I don't know if the word is hemostatic, but agents that can, that can slow down the blood flow. This has been very effective for fibroids, but something to bear in mind is if you have large fibroids and if you do a uterine artery embolization, if your OBGYN recommends that, it can be really painful because you're suddenly cutting off the blood supply to the fibroids and the fibroids start dying off. So think about if you cut off the blood supply to your hand, it starts to hurt. It's kind of like that. It can be really painful. Another treatment option is a uterine ablation, which is basically we're kind of burning the inside of the uterus. There are many different ways to do it, but basically we put inside a probe and heat the inside of your uterus to burn the endometrial lining. Something to think about is if you do that earlier on in your life, like say in your 30s, there is a high risk of not failure, but it's not permanent. Within 5 to 10 years, your bleeding might come back again. It's not unlikely to stop. But if you're close to menopause already, it might just get you over to the next few years and until you're in menopause and your bleeding should stop.
And if you're having children.
Yes, exactly. And then the last two options are hysteroscopy, which is where you put a little camera through the cervix and take a look inside of your uterus. We actually look and we can see fibroids, we can see polyps, we can take them out. And we can also do a dilation curettage, which is where we scrape the endometrium out. And last but not least, and most definitively, is a hysterectomy. The hysterectomy obviously is going to take away your source of bleeding because your uterus is gone. You can't bleed. But why it's not our first line treatment is because it's surgery. It's major abdominal surgery. And depending on various factors, it could end up being a big incision on your belly. There are minimally invasive ways to do hysterectomies. We could do laparoscopic, vaginal hysterectomies. I think Dr. Siddiqui is going to specialize really well in the vaginal hysterectomy category.
And I were just talking about how next week I think I have like 10 vaginal hysterectomies, which is basically doing the entire surgery from down below. No belly incisions at all. It's great. If you need it. If you don't need a hysterectomy, then we don't do it.
Exactly. You absolutely need it. So that's something to bear in mind. If you're asking for a hysterectomy with your OBGYN, your OBGYN doesn't want to do one, that's probably because they want to try less invasive treatment options before moving towards that category. Anything else you want to add on to that?
No, I think we've piqued a lot of interest. I'm happy to answer some of our questions.
Yeah, let's take a look. Is there any question that you saw that you wanted to answer?
You know what? A lot of people had these questions. Okay. So there's a pattern here in the questions that I'm seeing in that after having disclosed a lot of these problems with irregular bleeding to your respective gynecologists, that a lot of the responses that that our participants here have been given by their respective doctors is get married. We understand. We understand that culturally that getting married would then get you to hit your fertility goals sooner. However, the scope of this talk is about abnormal uterine bleeding. Getting married, starting the fertility journey is not the solution for abnormal uterine bleeding. It's not any of the solutions that we pose. It's certainly not a solution that I tell my patients when I counsel them. So I want us to not be married to that idea. I understand why trying to achieve fertility goals is important, but that is not going to fix uterine bleeding problems. And this is before I even address any questions. The only reason I'm saying this right now is because I see that it's a theme and it's a pattern, and we want to make it very clear.
Actually, just to add on to that, if anything, pregnancy causes abnormal uterine bleeding because you don't have a menstrual cycle. And something we actually, when we were practicing, we mentioned this, but we really want to make sure you do this at home is if you're not having a period, if you miss your period, first things first, do a pregnancy test. Always do a urine pregnancy test. You'll be surprised by the number of women we see who didn't do that and then realize that they're pregnant many months in. So low, cheap test, low intervention, always rule that out at home. If not, we'll do it in the clinic. 100% agree with what you said about married. There are many questions here. I think we have like 14 questions. I'm going to just pick and choose whatever comes first. Here's
something about the IUD. So it looks like somebody asked a question saying, at age 5, I have a copper IUD. Oh, we have another question about ablation. Sorry, got a little distracted. So
yeah. Go ahead, talk about that copper IUD.
Yeah, so this question is, at age 35, I have a copper IUD. How long is it effective? My cramps got worse since, and recently I'm having cramps the next day after intercourse, which I never had. The last time I took a pill was when I was 21. Okay, so the copper IUD is a non-hormone IUD. So I know that the one that we showed you is the Mirena IUD, and it itself, it's like a it's smaller and a little more plasticky, not as like more malleable than the copper IUD. That has hormone in it. The copper IUD does not have hormone in it. The reasons you are experiencing cramping is because the way that the copper IUD works is that it literally sits in your uterus and creates a toxic environment for sperm, so that when you do have intercourse, that sperm cannot go anywhere near an egg because that copper IUD is there. It's like literally a shield. It's a soldier in your uterus, okay? And if you can imagine, what would a soldier inside of your uterus do? It can wreak some sort of havoc and cause pain because it causes some inflammation around your uterus. So unfortunately, one of the biggest things that I hear from my patients, especially when they first get the copper IUD and within the first year, is a lot of cramping, particularly at the time of their periods. Because there's no hormone in it, most women do experience a period, but they do have a crampier period. It is extremely effective. Of the birth control methods we've talked about, this is the one that hits 99%. So if you you don't want to do surgery, you still want to keep your uterus, but you want to make sure you never have children again, it's the most effective birth control pill. So not pill, birth control option, one of the long-acting reversible contraceptives. It stays in for 10 years. So that's like its warranty. If you feel that the cramping has gotten too bad or the bleeding has gotten worse, we don't want you to live in pain or misery. There are other options. The only offset would be the other options have a slightly higher chance of still becoming pregnant when your goal was to not be. But it's an option. So
just kind of to take it home for this person who asked us, cramping is normal with that copper IUD. I would not be worried about that. That's like something that we counsel our patients on, that the copper IUD will cause more heavier bleeding and cramping. And why would then someone use a copper IUD? Well, it lasts for 10 years, so you don't have to take it out you can keep it in for longer. And second of all, it gives you the feedback that you're having a period. Some of the hormonal ones can reduce your period or cause abnormal bleeding or irregular bleeding. And sometimes for a woman, it's really important to know, okay, I'm having my period, I'm not pregnant. And getting that monthly feedback is really important. So those are kind of the two big benefits. If you have an allergy to copper, obviously you can't use this device. Another question I'm seeing here is something about how Plan B works. Where was the question? What does Plan B do, or the morning after do, and how to effectively use it? So Plan B is, as it's called, is Plan B. It should never be your Plan A, but we always keep it there as Plan B. And you use it to prevent pregnancy after unprotected intercourse. So if you were to have unprotected intercourse with someone, if you take Plan B within 72 hours from that incident, it will decrease your risk from getting pregnant. And how does it work? Well, when we go back to that cycle, when we talk about the follicular phase, the luteal phase, Plan B delays that ovulation. So if you were about to ovulate, that egg where it was about to rupture and go inside the fallopian tube, it delays that by a few days, so it prevents fertilization of the sperm and the egg. But it can only be taken within 72 hours. If it's not taken within the 72-hour window, it's not going to be as effective.
Anything else? Somebody who knows your menstrual cycle well and you have a good sense, like if you're somebody who is regular and you know that the day 14 days before you have your period, you've ovulated, that your ovary has released an egg. It's really important to keep this in mind, because if you do take Plan B after you have already ovulated, it's not going to be effective at all, which then kind of brings me back to the copper IUD. If you can, if you are at a place where if you've had intercourse and it's been 6 days since unprotected intercourse, the copper IUD, that will be like protective for you.
Yes.
Okay, I'm sorry, 5 days, but
5 days,
5 days, I said 6. So that's still like, it's 5 days, but what happens with the Plan B is, one, if you've ovulated already, it's not going to work. And two, as the longer you wait, like don't wait to the full 5 days. The most effective it is like the hour after. Yeah. But with the copper IUD, anytime within those 5 days is gold. But again, nothing's going to work.
Really, it's copper. It was a bad joke.
Yeah.
And also with the benefit of the copper IUD is you not only treat that risk of getting pregnant, but you also can prevent future pregnancies, whereas Plan B is just a one-time thing.
Making it clear, neither Plan B or the copper IUD causes abortions. That's not what these do. If you've already conceived, these medications or these alternatives are not going to do anything to kill the pregnancy.
Correct.
Making that clear.
Here's a question that I kind of want to just kind of talk broadly, question 10, which is talk about the common birth control solutions, the safest in your opinion. This question is not something we can answer, particularly because I don't know what this person's medical condition is. One, birth control A might be better for this person because of their medical history. So this is something that you need to have a discussion with your OBGYN. You have to go through your medical and surgical history, your age, your particular cause of abnormal uterine bleeding, and depending on that, the best treatment option, contraception, will be used. So do you have anything to add on to that?
No, I think one thing I like to at least say so that patients are aware is that ideally you should be started on a birth control that has the lowest amount of hormone. And then if you need it, if your body is still not responding, then increase. Because I think a lot of times patients who are unaware go to a doctor's office and a doctor just gives them a prescription with a really whopping dose of like progesterone, and maybe it wasn't necessary. So ideally, and this really goes for any kind of treatment when you're taking medications, start low and slow, and then go high if you have to. Those are unfortunately the best ways, but without doing an exam and seeing you and knowing you, we can't easily address it.
You can't necessarily say this is the safest for you. And that actually brings it back to the whole treatment for abnormal uterine bleeding. There are so many treatments. It's not like diabetes where the treatment is insulin, very one-to-one. With abnormal uterine bleeding, it's really a case-by-case basis. It has an extensive workup, and then it warrants a long discussion with the patient to figure out what's best for them. One question here is, can you please talk about ablation? Ablation is a choice to reduce and regulate heavy bleeding. So yeah, ablation, I don't know if it's offered in Bangladesh, but in the United States, we have 2 forms of ablation, hydrothermal and NovaSure ablation. So hydrothermal ablation is essentially, we put a camera inside the uterus, we take a look at the uterus, and we actually start filling the uterus with hot water, hot boiling water at a certain temperature, and it stays like that for 10 minutes. So actually we're just standing there for 10 minutes, and we'll, over the 10 minutes, see the endometrium just get cooked and charred and totally deteriorate. And that's been really effective to help with uterine bleeding. The alternative is a NovaSure ablation, which is essentially, this is the cervix and the device. The NovaSure ablation goes inside through the cervix into the uterus and then fans out. We take, the device can automate to the particular dimensions of your uterus. And then once it calibrates to that, it will buzz for anywhere between 30 to 90 seconds and really char that uterus. But like I said, this could affect your future fertility. So if you want fertility in the future, this might not be the best option for you. If you have a really big uterus, this might not be the best option for you. If you're very young, this might only work for you, temporize your symptoms, but it might not be a long-term solution for you. And also, last but not least, it also will make your biopsies in the future very difficult. So for example, if I'm 35, I had an ablation. I had menopause at 51 and I start having some bleeding, like when I'm 55 and I need an endometrial biopsy to sample that uterus, it can be very difficult to do that because I've charred the inside of the uterus. So it could be very difficult to detect cancer if there was one. So things to think of when you're talking with your OBGYN about ablation. Anything to add on to that, Dr. Siddiqui?
Say after, people like to say that the woman's womb is like a very hospitable environment. And it really is. It accommodates a pregnancy. It grows a placenta. But these ablation techniques are literally creating a not hospitable environment. It's kind of like creating a war zone inside of the uterus. And that's really so that you don't keep building blood vessels in your uterus that then shed, which is what's been causing your heavy bleeding. But afterwards, it is still possible to get pregnant. Unfortunately, a lot of those pregnancies then result in miscarriage. So that's why we're really like, try your best. If you're going to think about an ablation, really do it after you're sure you're done having children.
Okay. Question 14 was answered. I'm just getting some extra information. I just want to touch base. We're kind of running over time, and I'm happy to stay and answer questions, but I'm going to touch base with our team to see if it's okay to wrap up because we've run over time. But while we're waiting to hear back, we kind of wanted to wrap up. This is our very cursory discussion of abnormal uterine bleeding, and just really remind you that, this is our passion. These are a couple of action shots of us in the operating room. Dr. Siddiqui, what are you doing here?
Oh, I was delivering a 10-pound baby. I mean, we didn't know it was 10 pounds. I was trying to figure out why is it taking so long. That's what happened.
Yeah, I think we talked about it. I forgot which iteration of our. Yeah, and just really want to emphasize that Dr. Siddiqui and I, we met on the interview trail during my interview trail for residency, and we instantly hit. Our camaraderie is really based off of not only our work, but our shared heritage as Bangladeshi Americans. We're really proud to be Bangladeshi Americans, and it makes us so happy to see Bangladeshis everywhere succeed in whatever they want to succeed in.
So much for all of your questions. I'm clearly seeing a theme of PCOS here, and I think, Dr. Hussain, we need to do a whole thing on PCOS. Like, we're going to take note of all of your questions here, and we're going to try to answer those in general in that topic as well. But all of these questions that we have not answered here, they'll be forwarded to us, and we will, in written form, disseminate that information to you.
Yes, we are happy to take a look at your questions offline as well. I think that's really it. I don't think there's anything else to touch base on. Thank you so much for your time.
I had a great time.
Yeah, I had a great time. I felt like I was just hanging out with my friend. Yeah. We hope to see you next time. Asha kori porbe dekha hobe. In the meanwhile, be healthy, be well.
Bye, everybody.
Bye.